Okay, I hope you're seeing uh, skin infections on the screen.
Yeah.
Okay, good for us. Okay, off we go. I'm speaking to Vivian. Who am I there? Who's there?
It's
I'm
Kat,
here.
Who?
Erica, Vivian, Song, and Emma.
Oh, okay, that's more people than I can see. All right, got it. Off we go. Skin infections. So I thought we'd start with the most common ones. That's how I approached when I was doing the curriculum. Yeah, just starting with what's the most common. I think what I've selected today are the most common infections. So huh. Something's happened here. I don't know. Okay, there we go. Folliculitis. The hair. The hair is our weak point. And that's where bacteria can shinny down the hair follicle and cause all kinds of mischief. Um, this is obviously a more diffuse case. Um, and somebody's coming in here. Hold on. This is a diffuse case that's going to possibly take systemic treatment. This surely will. So you've got pustules here. So what do you think of when you see pustules? You want to culture that. You might be dealing with MRSA and something that bad. Very simple. Unroof it. And you'd think it wouldn't be very sensitive or specific, but it is. The way that they can process it in the lab, and it's always very helpful if you have a complication and they're not responding. So a lot of people this day and age, there are staph carriers in the nose. So you have to bear that in mind. And then the risk factors, stasis and pressure, obviously, and some of these, if not treated properly, can progress on to abscess. The first line of treatment would be an antibiotic ointment. If you can isolate it early, and this may be all that's required in the simple occlusion of a Band-Aid. Now, this says cream. That's wrong. I put it up here because you want it greasy. Particularly if there's a break in the skin and an early ulcer. Bacitracin. So polysporin and bacitracin are the best. The triple antibiotic, the only downside is neomycin. So just a red flag for you. Not everybody's allergic, obviously, but enough people are, and it can cause problem. So unless there's you're unable to get polysporin or bacitracin, you want to avoid neomycin. Sometimes you have to go with a systemic treatment, and here are the options. Keflex is our go-to first line. So that's where we're going to start, unless you have a penicillin allergy, and then you're forced to resort to these other options. And for MRSA, the go-to would be Septra, or the equivalent. Clindamycin is your last resort because it has some side effects. Oh boy. So what do you do when you've got a mess? And what you want to do are compresses, warm compresses. And so, what do we put in it? The dermatologist's favorite thing is dome burrow. What the heck is dome burrow? So don't burrow compresses. You loosen this up, gentle scrub, open it up so it can start healing from below. And dome is just an astringent. And it comes as a powder. You mix it up to create your compress uh, uh, solution. And astringent just chemically attacks the keratin and helps with shedding. The decolonization strategy. So when you have a frequent flyer, somebody who's susceptible to recurrent staph infections and folliculitis, you need to add to a decolonization strategy. And that can be either chlorhexidine, which is Hibiclens, but it also can simply be superchlorination, and that's Clorox. A quarter of a cup in a bathtub is quite enough. You all know how you feel when you've been in a pool that's been hyperchlorinated and your eyes water. Well, that's kind of what you're doing to eliminate the colony counts on somebody who's susceptible. And after they recover from an attack, you might want to set up a preventive schedule. Early on, it might be twice a week, then once a week, then maybe even once every few weeks. The other thing in a crunch, the old betadine, if you're just dealing with a regional infection, diluted 1 to 1 with water as a compress. So for cases that have progressed and maybe you've had an episode of MRSA, you need to go to something like mupirocin, not the over-the-counter polysporin or bacitracin, but mupirocin. And yeah, you may have to use that immediately, acutely, but you can also use it as standby for somebody that has that history. And you might give them standby Keflex as soon as they notice an early infection. They have that and they can get started without waiting to contact you. So let's say you've been treating folliculitis and your treatment's not successful, you're not getting anywhere. I sketched this out a few years ago. There's a lot going on around the follicle and folliculitis. This network of pathology, the hair follicle is the central problem. And there's usually some element that interrupts the hair follicle, like a comedone. And comedones are most acute in acne. Chronic comedones can end up in epidermal inclusion cysts, which you've probably taken out in minor surgery. Keratosis pilaris is really a form of atopic dermatitis, and that's what the first couple of slides showed. Somebody with a predisposition to too much keratin and obstruction. And then in people of color, I'm going to be showing you some slides of particular problems they have with hair-related inflammation. So the other thing, when you're not sure what's going on and you're not, you want to go back and look at your diagnosis, I recommend this book. It goes systematically through the whole body and the whole map of everything that can go wrong with the skin. And you'd work through this. This is a rash with epidermal involvement, pustular, and then you go to the chapter, and you always get this nice table. So if you think you've been dealing with folliculitis, but you're not getting any response, here are the other common causes of pustules that you see in primary care. And I'll run through all those, but this is the one at the bottom, rosacea. This is not a infectious pustule. There's no blackheads here. It is a folliculitis, however. And then, in addition to looking, Bill, I recommend as a second primary care reference for us generalists, Habif. And they've got a nice graphic as well on superficial folliculitis and what else could be causing it. So the rarer cases, and gram negative is a rare case. So when your first line treatment isn't working, you have to go back to the drawing board and see what other possibilities there are. I'm going to be talking about yeast folliculitis as well. Here are some rare causes. We'll come back to those. Hot tub folliculitis is the main cause of gram-negative folliculitis, and we see that here in California. Notice this follows the outline of the bathing suit. This is the yeast folliculitis. Less angry, but definitely a folliculitis. And this is a Pittosporum ovale, also known as Malassezia furfur. This is the one yeast that you're going to see the most of in primary care dermatology because it causes three things. It causes this folliculitis to start with, but I'll come back to the other two common things it can cause. And this is Tinea versicolor. This is Malassezia furfur as well, in a very different form. So it's a really a shape shifter. And the gestalt on this is clear with this complexion. This is about the only thing it could be, Tinea versicolor. But be careful, it's not tinea at all, it's yeast. And you can do a wet mount. That's what dermatologists want you to do, but you don't have time in primary care. I try to explain it, the way primary care is set up, and the infrequency of doing wet mounts. It's impossible, but a poor man's wet mount is Malassezia furfur is, you can evoke scaling very easy. You can evoke it, they can evoke it with their fingernail. So I think this has been a useful confirmatory sign that has a very high likelihood ratio. And if you were forced to do a wet mount, you'd see spaghetti and meatballs. But as I say, that's hard to do in primary care. And then the last thing in this triumvirate of things that Malassezia furfur or Pittosporum ovale can cause is seborrhea. Quite common in primary care, right up at the top. And this can be a cosmetic problem. It's certainly not a major skin infection that's going to progress. But here's the yeast, and it's very characteristic. It's seborrheic because it follows areas where there's a lot of seborrheic glands where sebum is produced, and that's the nasal labial fold, and also the chest. So this is seborrhea. And here is a map. This is from Looking Bill of other areas that produce a lot of sebum, the axilla, the back, and the scalp, and seborrhea of the scalp. We know is a real problem. So this is the big three, all caused by the same yeast. And so how do you treat that? Well, if it's just yeast, and you think you can manage it, a topical ketoconazole is the way to go, either the shampoo or the cream. But for really bad cases, like here you have a truck driver who's sweating a lot and has got a bad yeast folliculitis. It's really impractical to try to control that with ketoconazole solution or cream. So here you might have to resort to fluconazole, or in really bad cases, itraconazole. And there are bad cases of seborrhea as well that you might need to resort to systemic treatment. Yeast candidiasis, just to be complete. And of course, this is the serpiginous lesion of a good old fungal infection. And if you're not sure, I'd just go ahead and treat this presumptively. But if you're not sure, you can always culture it. And sometimes you don't want to shotgun it and make presumptive. But as long as you take a culture, the dermatologists, Dr. Page in particular, are perfectly comfortable making the call, starting the systemic treatment, but collecting a culture. And it's not hard to do. You just get a open ring curette, and scrape and make imprints on either of these media. So these are available everywhere. This is a number 2 or 3, and that's usually the size that works best to collect skin that you think is going to need systemic treatment. So I just throw this up here, and I'll pause for just a second and let you think about this is the kind of thing that we see in men of color. And it's not an infection. It's not an infection. If it's not an infection, what is it? And it's ingrown hair. And this is a nice diagram of the problem. And there's a lot of things you can do. There's handouts that go into detail on how to shave in particular, and how to treat. Also, in mostly men of color, is acne keloidis nuchae, and it's called acne. It's a misnomer. It's not at all like other forms of acne vulgaris, but it got the name because the treatment is the same. but it's unknown origin, and it can be quite bad. So here you'd need systemic antibiotics. Doxycycline would be the go-to, and then the same topicals. Tretinoic acid, or to open up the pores, or topical antibiotics. All right, so now we go to fungal infections. And the most common, particularly in young kids of color, and particularly in urban areas, is Tinea capitis. Now, this presentation just shows the typical black dots, but that doesn't have to be the way it presents. Here are all the ways. Here's black dots, but it can just be diffusely scaly. It can be gray. It can be pustular, carrion, boggy, many different ways it presents, and confused with all these other things. So take your culture and go ahead and get started. And as long as the culture is cooking, and it usually takes 3 weeks to get the result. So you don't want to just hold off for 3 weeks. You want to get going. This is not black dot. This is more scaly, but it certainly is regional. And then the black dot can be a little bit more subtle. But if you look here very closely, you can see black dots. What are black dots? They're just eroded hairs that can't even make it out of the follicle. They get to the top of the opening of the hair follicle, and they're so damaged they can't even make it out. A lymph node is definitely a confirmation that you're dealing with a significant tinea infection. I mentioned keratosis pilaris earlier. It's a genetic condition, quite common, and you'll see it on the lateral surface of the humerus, as we saw in the very first slides I showed today, the anterior surface of the thighs. Sometimes it's more subtle, and it may just be a curiosity. Sometimes it's a cosmetic problem. But it's considered to be a form of atopic dermatitis. And you treat it a little bit different, though. Here you have peeling agents, and tretinoin would be the way I'd start. I'd reverse this, but all these others are available. Ammonium lactate is the cheapest way to start if you're dealing with a very a mild case. Amlactin is the over-the-counter name for it. So amlactin is a good one to start with. But reassurance is the main thing. It's not going to progress. So is this follicular? No, this is vesicular. And this is herpes. The distinguishing characteristic is the pain. That's going to be painful. This is a fissure at the angle of the mouth. I bring this up because in the geriatric population, it can be common because of anatomic changes that account for the drooling that you hear about old people getting. Well, this constant moisture is a setup for a mixed infection. So it's a mixed infection of yeast and fungus and bacteria. So you have to shotgun the treatment. And then in addition, I'm going back to where we saw other causes of folliculitis and gram negative, but ectoparasites, scabies, obviously, but Demodex has recently emerged and is possibly associated with rosacea. And then there are other non-infectious etiologies. So scabies, and this is Demodex. And I'm going through all this pretty quick. This is non-infectious. This is from a sterile inflammation from waxing. I want to just breeze through acne because it's a very common form of folliculitis, but I see I'm at 132, so I need some guidance.
I think we'll probably need to wrap up. Because I think we've got some patients here. Yeah, it looks like we've got a couple people waiting, but this has been so excellent. Thank you so much for your time today, for joining us.
Yeah, my pleasure. Anytime, let me know.
Okay, does anyone have any questions for Dr. Lee before we let him go?
Would Dr. Lee be willing to send us his slides?
Would you be able to send out your slides and the recording?
Yes, I'll send out the link for the recording. So I'll stop the recording now and get that. I'll send it from my YouTube channel.
Okay, great. Thank you so much, Dr. Lee.
Thank you.
You betcha, anytime.
Happy holidays.
You too. Bye-bye.